In this video, we're going to be reviewing burns, and we're going to be updating our Southern Nevada Health District protocols as it pertains to burns. So to get started, let's talk about what a burn is. So a burn occurs when the body or body part receives more thermal, electrical, or chemical energy or is exposed to more radiation that it can absorb without an injury. Burns result in about 450,000 injuries per year that require medical attention, and it results in 3,400 deaths per year. So let's go over some pathophysiology about burns. So something to keep in mind about burns is that they are not isolated soft tissue injuries. They are actually systemic injuries. Think of it like this. You get a really bad sunburn on your back, right? You're gonna have pain to your back, and if it's a really bad sunburn, you're gonna end up having chills, nausea, and feeling sick, which is from the fluid shifts and electrolyte disturbances we're gonna talk about here momentarily. So a burn occurs, and when a burn occurs, norepinephrine and epinephrine get released by the body due to the stress and pain. When epinephrine and norepinephrine get released, this leads to vasoconstriction. When we talk about vasoconstriction, we talk about decreased blood flow. Therefore, we see a decrease in blood flow to the area of the burn. Then edema occurs from fluid shifting from the intravascular space and into the extravascular space, and sodium moves into the injured cells. When sodium moves into the injured cells, this causes fluid loss, loss of electrolytes, and ultimately this leads to hypovolemia. When we talk about a decrease in fluid volume, this leads to two things. One, hypoxia, two, hypovolemia. Let's take a look at the hypoxia first. So hypoxia is going to lead to tachypnea, which is going to lead to a decrease in metabolic acidosis and a decrease in hypoxia. This is the body compensating for that decrease in fluid volume. Now, when we take a look at hypovolemia, there's going to be a decrease in cardiac output, which is going to lead to hypotension, which is going to lead to vasoconstriction and tachycardia as the body tries to compensate, which as the body becomes tachycardic and starts vasoconstricting, that's going to increase the blood pressure and lead to an increase in perfusion. However, this is going to continue to decrease in cardiac output, which ultimately completes the shock cycle. So it's important to keep in mind that hypovolemia is an entire body problem. So when we talk about burns, burns are not just affecting the body part injured, they are affecting the entire body. Burns can be very detrimental. There's a bunch of effects of burns. So the first major effect of burns is the tissue damage that occurs. The skin is the most impacted organ. The skin is very important in reducing the body's ability to regulate core body temperature. And this is because fluid seeps into the damaged area, exposing it to the surface air, which causes evaporation. Evaporation leads to hypothermia. And also too, the tissue damage leads to an increase in risk for infection. The body no longer has the ability to prevent infection. So we want to make sure we keep these patients warm. If we do have a burn victim, keep them warm. Really important. Also, when we talk about burns, we have a decrease in fluid volume, which leads to less oxygen transported to cells. This can lead to hypoxia, acidosis, and anoxia. And lastly, one major effect of burns is that they can leave what's called eschar. And eschar is a tough, leathery substance that is not pliable. The problem is that edema increases and puts pressure on the underlying structures. Circumferential eschar can cause circulatory compromise and compartment syndrome. And if the eschar is around the chest, this will interfere with breathing. What you see on the photo is where they've had to cut through the eschar to allow for the chest to expand and contract. We call that procedure escharotomy. So let's talk about the different burn zones. So we have the first zone, which is where the majority of the damage occurs. And this is going to be the zone of coagulation. And there is little or no blood flow to this area. Then we have the zone of stasis. This is the peripheral area surrounding the zone of coagulation, which may undergo tissue necrosis within 24 to 48 hours. And last is the zone of hypernatremia, which is the area least affected by thermal injury. This area typically recovers in about 7 to 10 days. So now let's talk about burn depth. Now before we talk about burn depth, let's do a quick review of our anatomy of the skin. So when we talk about burns, we're mainly talking about the epidermis, the dermis, and the subcutaneous tissues. And these are the areas that are most likely going to be damaged. However, structures within these areas can be damaged as well. So when we classify burns, we classify them based on how far deep they go. So for example, a first degree burn is going to only affect the epidermis, whereas a second degree burn may affect the epidermis and the dermis, and a full thickness or third degree burn will go all the way down to the hypodermis. So we see here the varying levels of burns. So we have first degree, second degree, and third degree, and basically the level of impact they have on the tissues. Here is a example of a first degree burn, very superficial burn. Typically these are from like our sunburns or small cooking injuries. We'll see our first degree burns. The second type of burns we have are second degree, and the thing that really differentiates second degree from first degree is blistering. And then we have our full thickness burns, which go all the way down to underlying tissues. So it's very important that we make sure that we estimate burn size. So one way we have to estimate burns is through the rule of nines. The rule of nines assigns 9% to each body part. So we see here that the front of the legs represent 9% and the back of the legs represent 9%. The front of the body represents 18% and the back represents 18%. And then each arm represents 9% and then the head entirely represents 9%. We see here with children that the rule of nines is a little bit different and much more harder to calculate, as it doesn't follow the standard adult rule where everything represents 9%. However, infants are a little bit more easier to estimate. We see here that it follows more of that rule of nines, except for when we get into legs, which represent 14%. Another way that we have to determine burn size is through the rule of palms, and this basically assumes that 1% equals the patient's palm. Now, it is very important that if you are going to use the rule of palms, you use the patient's hand size for estimating the rule of palms. Don't use your hand size, only because your hand size might be different from that patient's. So let's talk about treating burns here in Southern Nevada. So this is our adult burn category. So if we do have a victim of an adult burn, we need to determine whether or not it was a thermal exposure or whether or not it was a chemical or electrical exposure. So for thermal exposures, we're going to start with stopping the burning process, removing any smoldering clothing and jewelry, and we do not want to remove any stuck clothing. If the patient needs ventilatory assistance, we're going to go to the ventilatory management protocol, and we do not want to cover the burned area with any ice, lotion, ointment, or antiseptic. We're only going to use a dry, sterile dressing. Advanced EMTs and above are going to initiate vascular access and are going to go with a fluid bolus. In the previous protocol update, we removed the Parkland burn formula, and now we're just going for IV fluid challenges at a set amount for the adult victim. So if the adult victim has more than 20% of the burn surface area present, or they are showing signs of hypoperfusion, we're going to go with a normal saline fluid bolus of 500 cc's. If additional fluid challenges are required, then we're going to contact medical direction at a burn center for further drip rates and additional boluses. We're going to continue with cardiac monitoring for paramedics and pain management for paramedics, and we can consider our smoke inhalation protocol. If the patient is a chemical or electrical exposure, we want to apply a cardiac monitor for paramedics. We want to determine if there's any eye involvement, and if there is, we're going to flush the eyes with water or normal saline for 15 minutes. And then we're going to remove any jewelry, constricting items, and expose the burn area, and try to identify any entry and exit sites and apply dry sterile dressings. As in over with the thermal exposure, if the patient is showing signs of hypoperfusion or they have more than 20% burn surface area present, then we're going to go ahead and initiate a fluid challenge with 500 milliliters of normal saline. And paramedics are going to initiate pain management. Now, all patients that meet burn criteria are going to be transferred to the closest appropriate burn center. Now, with this protocol update, Sunrise Hospital is now listed as an approved burn center in addition to UMC. For the adult smoke inhalation protocol, we're going to initiate the general adult assessment. We're going to place the patient on a non-rebreather at 100% oxygen, and if the patient requires ventilatory management, we're going to ventilate the patient and follow the ventilation management protocol. We're going to apply the cardiac monitor, and advanced EMTs and above are going to go ahead and initiate vascular access with a normal saline bolus, 500 milliliters up to a max of 2,000 milliliters for hypoperfusion. Other treatment protocols are going to be as indicated. We're going to go ahead and determine if the patient is in cardiac arrest or hypotension or profound profound altered mental status. If the patient is found to be in any one of these states, then we're going to go ahead and administer hydroxycobalamin, 5 grams IV over 15 minutes, and transport to the closest burn center. If the patient is not in any one of these states, however, they are showing signs of smoke inhalation, then we are going to go ahead and transport to a closest burn center. Once again, Sunrise has been added in this protocol update as a burn center. For pediatric burns, they're very similar to our adult burns. Once again, we're going to go ahead and determine whether or not the burn is due to a thermal exposure or a chemical exposure. If the burn is the result of a thermal exposure, we're going to stop the burning process with water or saline. We're going to remove smoldering clothing and jewelry, and we're not going to remove the stuck clothing. We're going to go ahead and continue with ventilation management, and we're going to cover the burned area with dry, sterile dressings. We don't want to use any ice, lotion, ointment, or antiseptic. Advanced EMTs and above are going to go ahead and initiate a IV fluid bolus. If the patient's over the age of 13, we're going to give a 500 milliliter fluid bolus. For age 6 to 12, we're going to give a 250 cc normal saline fluid bolus. And if the patient is 5 years old or less, we're going to go ahead and administer a 125 milliliter fluid bolus. And these are all going to be administered if there are signs of hypoperfusion or if more than 20% of the burn surface area is present. If additional fluid challenges are required, please contact medical control for those additional fluid boluses. Paramedics are going to apply the cardiac monitor, consider pain management, and then consider smoke inhalation for all levels. And lastly, transport to the burn center. If the patient is a chemical or electrical exposure, we want to go ahead and apply the cardiac monitor. If the patient has been involved in a chemical or electrical exposure, paramedics should apply the cardiac monitor. We're going to go ahead and determine if there's any eye involvement. If so, we're going to flush the eye with normal saline for 10 to 15 minutes. And we want to remove any jewelry, constricting items, and expose the burned area. We want to identify any entry and exit sites and apply dry, sterile dressings. Just as before in the thermal exposure, fluid boluses are administered based on the patient's age, and if additional fluid boluses are required, we want to go ahead and contact medical control. Paramedics will need to consider pain management, and lastly, patients will be transported to the closest burn center, whether it be Sunrise or UMC. So for pediatric smoke inhalation, we're going to initiate the general pediatric assessment protocol. We're going to administer oxygen to keep the pulse oximetry greater than 94%. We may consider ventilatory management, and we want to apply the cardiac monitor if you're a paramedic provider. Advanced EMTs and above are going to go ahead and initiate vascular access and are going to administer fluid based on the patient's weight. The weight-based calculation is going to be 20 milliliters per kilogram up to 60 milliliters per kilogram for hypoperfusion. We want to follow other treatment protocols as indicated, and we want to go ahead and determine if the patient is in cardiac arrest or hypotension or profound altered mental status. If the answer is yes, we want to go ahead and administer hydroxycobalamin as outlined in the pediatric pearls, and then transport to the closest burn center. If the patient is not in cardiac arrest or hypoperfusion or profound altered mental status, then we are going to go ahead and transport to the local burn center, whether it be Sunrise or UMC. On the screen now, we see that we have the pediatric cyanokit instructions and dosing. So we want to go ahead and administer the cyanokit based on the patient's weight and based on the patient's age. And it's very important to make sure with any patient that we keep these patients warm. Now, we want to go ahead with any burn patient. We want to determine whether or not they are a candidate for a burn center. According to the Southern Nevada Health District protocols, patients meeting the following criteria shall be transported to the closest appropriate burn center. So any patient with a second-degree burn with more than 10% of the body surface area, any third-degree burns, burns that involve the face, hands, feet, genitalia, perineum, or major joints, electrical burns including lightning injury, chemical burns, circumferential burns, and any burn injury with concomitant trauma. As outlined before, Sunrise Hospital is now a burn center. They opened their burn center on October 1st, 2019. They are now a comprehensive burn center for both adult and pediatric patients, and they are recognized by the Burn and Reconstructive Centers of America. So Sunrise Hospital is capable of seeing adult and pediatric burn patients. They can receive burns associated with chemical, electrical, friction or road rash, frostbite, inhalation, radiation, and thermal injury. They have 24-hour hyperbaric oxygen therapy, which can cover carbon monoxide poisoning, dive wounds, and wound healing. They have burn and reconstructive surgery, including laser scar therapy and scar revision. And they can treat skin and soft tissue disorders, including diabetic wounds, gangrene, necrotizing fasciitis, necrotizing soft tissue diseases, skin sloughing disorders, staphylococcal scale skin syndrome, and Stevens-Johnson syndrome, and toxic epidermal necrolysis. Sunrise Hospital is part of the nation's largest burn network, and they have burn networks all throughout the country. Also, UMC is still a burn center. You can go ahead and transport to the Lions Burn Center at UMC if the patient has a burn. Next up, I have a video presentation for you regarding how to administer the cyano kit. Please take this time to review this video. It is from the manufacturer of cyano kit on how to administer their product.
Administration instructions for Cyanokit, hydroxycobalamin for injection, 5 grams. Cyanokit is indicated for the treatment of known or suspected cyanide poisoning. If clinical suspicion of cyanide poisoning is high, Cyanokit should be administered without delay. There are no contraindications for administering Cyanokit in the field. Serious adverse reactions with hydroxycobalamin include allergic reactions and increases in blood pressure. Important safety information is available at the end of this video. You can view full prescribing information at cyanokit.com. This video includes a simulation of the preparation and administration of the Cyanokit 5-gram vial and is intended for emergency medical personnel and first responders. In it, we'll describe the signs and symptoms of cyanide poisoning, dosing for Cyanokit and how to administer it, as well as selected safety information. Cyanide poisoning may result from inhalation, ingestion, or dermal exposure to various cyanide-containing compounds, including smoke from closed-space fires. To learn more about cyanide and potential sources of poisoning, please visit cyanokit.com. Prior to administration of Cyanokit, smoke inhalation victims should be assessed for exposure to fire or smoke in an enclosed area, presence of soot around the mouth, nose, or oropharynx, and altered mental status. Not all smoke inhalation victims will have cyanide poisoning and may present with burns, trauma, and exposure to other toxic substances, making diagnosis particularly difficult. Currently, there is no widely available rapid confirmatory cyanide blood test. So treatment decisions must be made on the basis of clinical history as well as the signs and symptoms of cyanide poisoning. Some common signs to look for include disorientation, mydriasis, and vomiting. Common symptoms of cyanide poisoning can include headache, dyspnea, and chest tightness. It is important that treatment decisions be made using appropriate medical judgment by emergency medical personnel. If clinical suspicion of cyanide poisoning is high, based on signs and symptoms, Cyanokit should be administered without delay. There are no contraindications to administering Cyanokit in the field. Serious adverse reactions with hydroxycobalamin include allergic reactions and increases in blood pressure. Consideration should be given to use of alternative therapies if available. Most other reported side effects from Cyanokit were generally mild to moderate and resolved spontaneously. Please note that skin redness may last up to 2 weeks and urine coloration may last for up to 5 weeks. Comprehensive treatment of acute cyanide poisoning requires support of vital functions. Cyanokit should be administered in conjunction with appropriate airway, ventilatory, and circulatory support. Now, let's talk about dosing for Cyanokit. The starting dose of Cyanokit for adults is 5 grams administered as an intravenous infusion over 15 minutes. Administration of the entire vial constitutes a complete starting dose. Depending upon the severity of the poisoning and the clinical response, a second dose of 5 grams may be administered by intravenous infusion for a total dose of 10 grams. The rate of infusion for the second dose may range from 15 minutes for patients in extremis to 2 hours as clinically indicated. Now that we've explained what to look for in a potential victim of cyanide poisoning and dosing for Cyanokit, let's take a look at what comes in a Cyanokit and how to administer it. Each Cyanokit contains one 250 milliliter glass vial containing 5 grams of lyophilized hydroxycobalamin for injection, 1 sterile transfer spike, 1 sterile intravenous infusion set, 1 quick-use reference guide, 1 package insert. The recommended diluent is 0.9% sodium chloride. Lactated Ringer's injection and 5% dextrose injection have also been found to be compatible with hydroxycobalamin and may be used if 0.9% sodium chloride is not readily available. Please note that the diluent is not included in the kit. The following is a simulation of the preparation and administration of Cyanokit performed in a controlled setting. Please be advised that in a true emergency situation, other supportive therapies may be in progress, including basic and/or advanced life support. With the 5-gram vial in an upright position, begin by reconstituting the hydroxycobalamin with 200 milliliters of diluent using the supplied sterile transfer spike. The line on the vial label represents 200 milliliters of diluent. Hold the vial level to make sure the diluent reaches the fill line. Following the addition of diluent to the lyophilized powder, the vial should be repeatedly inverted or rocked, not shaken, for at least 60 seconds prior to infusion. The hydroxycobalamin solution should be visually inspected for particulate matter and color prior to administration. If the reconstituted solution is not dark red, or if particulate matter is seen after the solution has been appropriately mixed, the solution should be discarded. The solution is now ready to be infused. Using the supplied vented intravenous tubing, hang and infuse over 15 minutes. Because there are a number of drugs and blood products that are incompatible with Cyanokit, it requires a separate intravenous line for administration. Hopefully you've learned what to look for in a potential case of cyanide poisoning and how to treat it with Cyanokit. Now, here is some safety information you should keep in mind. Caution should be exercised when administering other cyanide antidotes simultaneously with Cyanokit, as safety has not been established. If a decision is made to administer another cyanide antidote with Cyanokit, these drugs should not be administered concurrently in the same IV line. Cyanokit also has certain incompatibility issues that should be recognized for safe administration. It is incompatible with select drugs used in resuscitation efforts, with sodium thiosulfate and sodium nitrite, and with ascorbic acid. Administration of blood products through the same line is also not recommended. Because of its deep red color, hydroxycobalamin may cause hemodialysis machines to shut down due to an erroneous detection of a blood leak. This should be considered before hemodialysis is initiated in patients treated with hydroxycobalamin. Use caution in the management of patients with known anaphylactic reactions to hydroxycobalamin or cyanocobalamin. Consideration should be given to use of alternative therapies if available. Allergic reactions may include anaphylaxis, chest tightness, edema, urticaria, pruritus, dyspnea, and rash. Allergic reactions including angioneurotic edema have also been reported in post-marketing experience. Substantial increases in blood pressure may occur following Cyanokit therapy. Elevations in blood pressure, greater than or equal to 180 millimeters mercury systolic, or greater than or equal to 110 millimeters mercury diastolic, were observed in approximately 18% of healthy subjects receiving hydroxycobalamin 5 grams and 28% of subjects receiving 10 grams. The most common adverse reactions, greater than 5%, included transient chromaturia, erythema, rash, predominantly acneiform, increased blood pressure, nausea, headache, decreased lymphocyte percentage, and injection site reactions. Cyanokit should be used during pregnancy only if the potential benefit justifies the potential risk to the fetus. The safety and effectiveness of Cyanokit in pediatric patients have not been established. In general, the safety and effectiveness of hydroxycobalamin in elderly patients was similar to that of younger patients. No adjustment of dose is required in elderly patients. No data are available about overdose with Cyanokit in adults. Should overdose occur, treatment should be directed to the management of symptoms. Cyanokit should be stored at 77 degrees Fahrenheit, with excursions permitted from 59 degrees to 86 degrees Fahrenheit. It may be exposed during short periods to temperature variations of usual transport, transport in the desert, and freezing or defrosting cycles. Once reconstituted, hydroxycobalamin is stable for up to 6 hours at temperatures not exceeding 104 degrees Fahrenheit. Do not freeze the reconstituted solution. Any reconstituted product not used in 6 hours should be discarded. Please keep watching for important safety information on Cyanokit. Indication: Cyanokit, hydroxycobalamin for injection, 5 grams, for intravenous infusion is indicated for the treatment of known or suspected cyanide poisoning. If clinical suspicion of cyanide poisoning is high, Cyanokit should be administered without delay. Important safety information: cyanide poisoning may result from inhalation, ingestion, or dermal exposure. Prior to administration of Cyanokit, smoke inhalation victims should be assessed for exposure to fire or smoke in an enclosed area, presence of soot around the mouth, nose, or oropharynx, and altered mental status. In addition to Cyanokit, treatment of cyanide poisoning must include immediate attention to airway patency, adequacy of oxygenation and hydration, cardiovascular support, and management of any seizure activity. Use caution in the management of patients with known anaphylactic reactions to hydroxycobalamin or cyanocobalamin. Consideration should be given to use of alternative therapies if available. Allergic reactions may include anaphylaxis, chest tightness, edema, urticaria, pruritus, dyspnea, and rash. Allergic reactions including angioneurotic edema have also been reported in post-marketing experience. Substantial increases in blood pressure may occur following Cyanokit therapy. Elevations in blood pressure, greater than or equal to 180 millimeters mercury systolic, or greater than or equal to 110 millimeters mercury diastolic, were observed in approximately 18% of healthy subjects receiving hydroxycobalamin 5 grams and 28% of subjects receiving 10 grams. Usage may interfere with some clinical laboratory evaluations. Also, because of its deep red color, hydroxycobalamin may cause hemodialysis machines to shut down due to an erroneous detection of a blood leak. This should be considered before hemodialysis is initiated in patients treated with hydroxycobalamin. Due to potential photosensitivity, patients should avoid direct sun until erythema resolves. There are no adequate and well-controlled studies of Cyanokit in pregnant women. Cyanokit should be used during pregnancy only if the potential benefit justifies the potential risk to the fetus. Safety and effectiveness of Cyanokit have not been established in pediatric patients. The most common adverse reactions, greater than 5%, included transient chromaturia, erythema, rash, predominantly acneiform, increased blood pressure, nausea, headache, decreased lymphocyte percentage, and injection site reactions. View the full prescribing information for Cyanokit at cyanokit.com. For medical questions concerning Meridian products, to report an adverse event, or to speak to a member of Pfizer U.S. Medical Information, please call 1-800-438-1985. To order Cyanokit or to request additional training materials, please call a Meridian representative or visit cyanokit.com.